my little floating head.
Hello, everybody. It looks like we're live. We see.
Wow, there's people here already.
37 of you are here. Fantastic.
Wow.
So,
hi.
Hello.
We're broadcasting a little more virtually today. Shea is at home.
I am. We're finally complying with social distancing over here.
Can you guys hear her okay? Can you guys send us a message on the comment thread if you can't hear Shea?
Is my voice coming through okay? Let us know if you can't hear.
So Shea's going to kick it off, I think, right? With the numbers, what we have, like update on the numbers, where things are these days.
Yeah, I have the Orange County numbers again in front of me. So we've been keeping a close eye on these, and the Orange County Public Health website is updating these daily. So these were refreshed yesterday, and we'll see, maybe even during this hour, we might get the last 24 hours numbers. But as of yesterday midday, total COVID cases in Orange County to date are at 931. So you'll remember from last week, Wednesday at this time, we had just reached 600. The day before that, it was 500. So, you know, in the 3 weeks prior to that, we had only gotten to 500. And so this has been a week where we're seeing that caseload increasing. But some of these other numbers are a little more encouraging. So cumulative cases is 931. Total deaths in Orange County to date, we're at 15 right now. So 50 cases were reported yesterday. Cases currently hospitalized is 129 right now, and of those, 75 are intensive care level of care. So those are our current numbers. I don't have the LA County ones in front of me, but I think, yeah, so we have been just giving the Orange County ones so far to keep it local.
Yeah.
So.
Thank you. So one of the things that I felt we should talk about, which is on everyone's mind and which we're going to answer and not answer all at the same time, is a timeline. So what is this looking like as far as how long this is going to take? You know, when are we going to reach our peak here? How long are we going to be social distancing? All of that. So you know, we're reading more and more. People are giving more specific predictions on what might happen as far as timing goes, although these still tend to change. So it's one of these things where we could say one thing today and then it changes next week. But we wanted to at least kind of give a sense from what's out there and what people are predicting about what's to come. One of the things that they're predicting is that there's clearly New York is sort of the epicenter in the United States for COVID. And the peak in New York is expected to come around April 9th, which is very soon. What's today, the 8th? Mm-hmm. So that's tomorrow. And so we'll see if that prediction is true. And in California, where we've seen a much flatter curve, meaning in California, we put social distancing in a bit earlier, and maybe that's why, maybe not. But we've seen in California, the cases have not spiked like they have in New York. We've sort of had this gentle increase in cases. And so they're thinking, at least at this point, this could change again, that the peak might be around April 17th. So if we think of that as the peak, what happens after that? What do we do? Maybe things are going to start to slow down, you know, come May or June. And so what does that look like? Will we be able to relax social distancing at that point? It's interesting to ponder that. I think that most likely some things will start to change come May or June. As far as schools being open and all of that, it almost seems like schools are going to be closed for the rest of the school year from what we're guessing. Again, we don't know. Things can always change. But it seems like the schools probably will be closed. I don't know. Do you guys have comments on that?
Yeah, some of the unified school districts locally have already anticipated being closed, being virtual only throughout this year. So likely, I mean, we're already almost mid-April. You know, once again, these are coming from combining a lot of what's out there in the data and once again making guesses as to where we're going to be. And I have a feeling that these social distancing measures will be extended for at least a few more weeks. And the reason being is that it seems to be working. And at least from this health perspective, clearly there's also downsides to it, which we're hopefully can address as a community. But from a health perspective, it seems to be an effective way of handling things. So yes, it seems that that's the case for many public school districts have announced that officially. And it's probably a domino effect where that's going to trickle down to other school districts and private schools, et cetera.
So what that means for a time, oh yeah, please, you go.
Oh, I was just going to say, and maybe you were going to talk about this, Emily, but as we start looking forward, and it still even feels a little early to start doing that, but looking forward to what that'll look like, the relaxing of these social distancing, it's very likely that that's going to be gradual. It's not going to be all of a sudden one day we snap our fingers and life goes back to normal. So it'll probably be a graduation of things opening back up. And so to me, it has seemed like the schools, since most in California, that I'm hearing of have already announced that rather than going back and forth, doing virtual, now all of a sudden we're going to switch back. They're most likely going to just ride out the rest of this school year virtual. That seems most likely to me at this point, but that doesn't mean that it won't be until next August that everything, stays shut down. I think it's much more likely that we'll see this happen, slowly and along a spectrum.
Right. Doesn't it seem, you guys, like the schools are sort of the tightest held, or they're going to be the last thing that are opened up?
Yeah, I think that's what I'm trying to say. Yeah, because that's just such a easy place for transmission. I mean, there's such high risk of transmission in that setting. So
and clearly we're like
safer settings.
We're like the last ones to know here. Everyone's texting us. The schools are closed. So I guess you guys all know that already.
Right.
So then the question is, if things kind of open up in the summertime, and I wonder, and I hope that schools open in the fall. And it's hard again to get this far out, but I just wanted to put this out there because it's something that's on my mind that we've talked about. Sort of what happens then if the schools open again. We may actually see another wave of this in the fall, late fall, winter next year. And it's possible, again, I don't know, but the schools could close again in the winter of next year. And then after that, are we going to see another wave in the spring? And then will we have a vaccine in the spring 2021? And that's when we can start to really return to life fully as normal. So we may be looking at this sort of tempered reintroduction of life and see how things go. So.
Mm-hmm.
So that's a good segue, because I think we've had a lot of discussion internally here about how we communicate with everybody. And the big things that you've noticed that we're talking about is a lot of uncertainty, and we don't have clear answers. We don't have dates to give you. There's a lot of guessing that we're doing. So one of the things we're going to start to talk about now and kind of bookend this whole thing is this whole topic of uncertainty and how that's affecting us and our ability to make recommendations, and why the language we're using sometimes isn't so heavy-handed and clear that a lot of people want and sometimes need in this anxiety-provoking time. So we did want to provide a little more clarity, and this is an opportunity. And when we discussed earlier, this is kind of this window into what has been kind of our lives for a long time in terms of dealing with uncertainty and talking with you. And there's a lot of things we don't know. That's an ongoing process to figure out, and that really has been the scientific method, this current scientific method in the past, in the present, and in the near future. This is how it's always been done. So I kind of wanted to kick it off, and there's been some great articles and talk about, there's questions that we're going to address about antibody testing, hydroxychloroquine, prophylaxis, lots of really great questions. What does it all mean? And at the end of it, there's some useful information to be gained from it, but no clear black and white answers that we can apply to everybody. So I don't know if somebody wanted to speak about that uncertainty that we're dealing with in this time.
Yeah, I mean, we all three of us have been having some good conversations about this, and James and I were talking this morning. It's kind of like one way of looking at it is, in some ways, this huge crisis that we're all going through globally is almost like pulling back the curtain on a way of thinking that is really ingrained in us in the medical community as doctors and throughout our training to always be kind of simultaneously weighing risks and benefits, understanding that the scientific method isn't perfect. It takes time to come to consensus statements and total clarity on things. And so often, as we're making medical decisions together with you every day, we're and hopefully you all as our patients have experienced more of that transparency within our practice of, presenting you with as much information as we have. And then all together, we weigh your personalized situation, what your particular risks might be, what your, specific health conditions are, all of these things that we're taking into account, your own comfort level with taking on risk. I mean, that's a huge part of it too, beyond just the kind of objective medical conditions. So that's kind of, how the medical community is trained and how we work. And then so much of that, so often though, that doesn't get translated to the public. Like what you hear is very hard and fast guidelines that, and that's kind of the more traditional way of practicing medicine is just, dictating this is, with 100% certainty the way we should handle this condition. And there's a consensus statement on that. And we all kind of want that right now. We would love to have some more certainty, but welcome to our world in some ways of really, needing to, so we all want to be in this together, presenting you with, an informed perspective, and we're all constantly reading up on this daily, and we're trying to present you with the best information, but a lot of this is going to be, the questions of the particulars of how to proceed and, the little individualized daily decisions that you're all needing to make with all of this. So, hopefully we can walk you through that, but it's individualized for everyone. So I don't know.
And this sort of dovetails into, it's something that I've really been, again, trying to communicate too with people is when we grab the scientific method and take it all the way to the end to a conclusion when we're really at the beginning, is where we get ourselves in trouble. And we're going to talk about that when we start to talk about hydroxychloroquine and treatment options where, and we can give you guys examples of this in medicine and history with, with heart failure treatment back in the day. We used to think, well, it makes sense. It worked in short term for these people. We gave them these drugs and made their heart beat faster. And then when we looked at it over the long run, it actually was killing people and making them die quicker. And there's so many examples of this where our very early introduction of a medicine looks so promising and not always, but sometimes it turns out to actually be causing more harm than good. So it's this jumping. We so badly want information so quickly, and understandably so. But we got to be so careful about taking that information too far and then doing harm. We read this great article. My mom actually sent it to us. It's on 538. And one of the author wrote, at the end of the day, experts told me when evidence is lacking, individuals and public health officials alike have to make a call based on what we do know, our personal experiences, and our own understanding of risk and risk management. So that's kind of summing up what Shea was saying a little bit there about this. And so that kind of gets into, and I see you guys asking questions about when your cleaning lady can come and stuff. I want to answer that, but maybe we can talk about masks now, because I think that gets into, last time the three of us were talking, we were kind of, you could see, we were kind of looking at this through a little bit of a different lens and different risk tolerance, different perspective on things, and all couched in that uncertainty. So last time when we were talking about masks, we were kind of saying, maybe a cloth face mask, it seems like it's droplet. And now the CDC is coming out and talking about masks a little more widely being used. And there are some questions about, could this have some airborne transmission? Again, there's just so much uncertainty. So I don't know if you guys want to talk about, for me personally, what we've decided if the thought is, for me, if we're coming to the peak in the next 10 to 14 days here in California, over the next 2 weeks, I'm going to be, if I'm out in the grocery store, I'm going to be wearing a mask. We decided to do this social distancing here today. When Nancy and I are in the office together and we're close, we're going to have a mask on just for this time period. So I don't know if anybody has more questions about that. We've kind of beat the mask thing.
Right. So there's once again, going to the uncertainty, there's no clear answer. Like, is it airborne? Is it not? Great questions from before. The answer is we're not really sure yet. And so when we start making these recommendations, and that's why it took so long, because you have to weigh the risk benefits of recommending masks, because there's a slight risk too that people don't use them correctly. They don't practice the same social distancing. So there are really challenging decisions that need to be made based on, once again, the evidence that we have, which isn't that much. So, once again, going to the mask thing, if you're going to a crowded place that you can't practice social distancing, then yeah, we should all wear a mask. And that's really where the recommendation is. And it's not because we know that it is airborne or it's not airborne. That's not why. It's because we're not sure, and this is probably a better benefit than risk. So that's why these guidelines that Shea was alluding to are being made and being changed. And that's why we're having these things so regularly, because things are changing. You're seeing the early process of discovery, right? We're all part of this, and it's anxiety provoking at the same time. So hopefully we can help out with that.
Another point that I thought was important, that 538 article that Emilie mentioned talks about was, and again, specifically with this mask discussion, it's something where two different, very well-informed and well-studied experts within this field of infectious disease and epidemiology could come down on different sides and have come down on different sides of the mask debate. So these things are not straightforward. You can be really well informed about it and not come to the same conclusion. So we'll do our best to help guide you through that. We're doing our best on our own and, with each other and our families to come up with our own personal decisions. But yeah.
There's one thing that, and you guys can tell me if I'm being overconfident, but one thing that seems fairly clear to me is this is not spreading like something like measles, where if someone were, and a couple people asked this, if James and I are walking around the neighborhood, we're walking with my mom, she's 6 feet away, none of us have a mask on, we're outside. Measles would sit in the air for hours, and if you walked by, you could get, measles is so contagious, and there's such clarity that this is not spreading like measles does, or else honestly we would all have it. And that's not what's happening. With what we're doing, because what we're doing is working, it makes me pretty confident that unless I'm in an enclosed space with someone and they're talking or coughing, I don't need a mask, right? So like me and Nancy in the office together and we're next to each other because we have to hand things to each other, maybe we should have a mask on. We're in the grocery store, someone's walking by the tight aisle right next to me, maybe I'll put a mask on. Still, I think the risk is low in those situations, but a mask I don't think will hurt. So.
And going to that point, people ask about walking in the neighborhood, and I would say, it's your personal risk, how you feel, but we'll tell you, we don't wear masks when we walk in the neighborhood because we don't feel like we're in an enclosed space. We're not lingering by people. And I think for us, we feel comfortable walking in our neighborhood without a mask.
If you were in New York City and you were walking in the neighborhood,
so
which is like, forget it.
Neighborhoods
you need to put a mask on.
Neighborhoods have a lot of different definitions too. So that is a clarification that I think is important. If it's crowded, it's a crowded neighborhood and everyone's on the street and bumping into each other, then you should probably wear a mask. But on a case by case, if I'm walking and there's nobody around me, I feel comfortable not wearing a mask.
Yeah, it seems like at most in like they were talking about last week, this laboratory experiment, the virus can hang in the air for a little while in very low volume. Like it just seems very unlikely when you're outside and there's a cross breeze, and that just seems, I don't know. For me, talking about personal risk, I much prefer not to put a mask on when I'm walking around my neighborhood.
Right. So. But it absolutely does depend on how dense it is and how populated. I'm thinking about, to get specific, last week, we, our whole family went on a walk in Newport Back Bay, and we do that frequently. And it was pretty crowded. It was a sunny day after some rain. And even though it was outside, people were close enough on those trails. If I was going to do that again this week, again, with the context of this being this week and next week projected to be the highest peak times where there's, the most increase in cases going on, with that information and additional information coming in. If I went to Newport Back Bay on those trails, I would probably wear a mask this week. But in my neighborhood, I still feel spaced out enough.
Maybe you wouldn't go to Newport Back Bay.
Maybe it's close
maybe
now.
Maybe the next 2 weeks you won't go.
Trying to socialize my new puppy. I gotta do something.
That's true. So that's the recommend in general for the mask. Once again, enclosed space, lots of people can't social distance. For sure, wear a mask. It's the risk benefit there. The benefit outweighs the risk. If there's any benefit, it's that if you're asymptomatic, you're not going to spread it to others. Let's put it to that perspective too. And still be mindful of the other precautions we've talked about in detail. Don't touch your face. Don't fiddle with your mask. And that's one of the cons of the face mask is people don't know how to wear the face mask. So if you're touching your eyes, right, and adjusting this, and you're on the shelf and doing things, and your eye itches and all that kind of stuff, it kind of defeats the purpose. So just still,
I have to give a particular example of that. I just saw, I was in the grocery store a couple days ago, and someone was wearing a mask, but he constantly, many times while he was shopping, would pull it down grab the front of the mask, take it down, talk on his cell phone.
Oh, gosh.
Take it down, talk on his cell phone.
Right.
Yeah. I saw him do it multiple times while we were kind of circling each other in the grocery store, and it was all I could do not to go say something. I would have, but he was on his phone the whole time. So that is exactly what we're talking about. If not the best way, you don't want to touch the front of the mask. Assume that the front of the mask is contaminated, and only touch the side. Purell or hand sanitize your hands right afterwards, or wash them if you can after removing the mask. And we talked about this last week, a huge, reason for wearing the mask is just as a reminder to not touch your face. And I find it pretty helpful just for that. So while you're out and about and before you can wash your hands, it's a helpful
don't touch your face.
Way to remind you of that. Yeah.
And then, so, travel, if you have to travel for work, that's a question. I mean, take as precautions as you can. You're going to be in tight spaces, social distancing. You really have to be cautious. I think a face mask is definitely something reasonable to do. And, if you have hand sanitizer, wash your hands, all the same precautions if you have to do that and engage in that.
And yes, if you have a cloth mask and you wear it, I would wash it for sure. Why not? After you wear it, and if you're out and about,
Yep.
Okay. Treatment. So this is a big topic. A lot of people are asking us about treatment options. Let me turn this off. Sorry about that. A lot of people are asking us about treatment options. And clearly there's a lot of confusion, particularly about hydroxychloroquine. And so I'm going to take a little time to talk about that. Hopefully I don't lose you guys here with this.
What's the upshot? So start with the
upshot is back to, and Max, we're going to talk about COVID tests. We're going to get there. That's our next thing. The upshot is that we don't know. It is very early. That's why I was talking about examples of us doing harm by making too quick conclusions. So it's too early to make any true statement about hydroxychloroquine. And I am actually somewhat, dumbfounded, exasperated, amazed at how much positive press hydroxychloroquine has gotten when you actually break down what's out there. I mean, it's crazy to think of how much we're pulling this into this being this savior drug when it's just what's out there. So let's talk about what's out there. Yeah, you go, Shea.
I was just going to say, I do think it's somewhat understandable. I mean, everybody wants to cling to something, but there can also be danger in that. So, good to look at the data, which Emilie is going to help us do.
Right. So this, James and I have been reading everything we can. And it's funny, we have this doctor textbook called Up to Date, which is great. But we felt like this article actually, is it backwards for you guys? It is, huh? Okay, so this is from Vox, and it's an article written April 7th, and it's called "The Evidence for Using Hydroxychloroquine to Treat COVID-19 is Flimsy." So basically, this article I felt like was a really great summary about why, thanks guys for telling me it was right, why the evidence that we have out there is shaky. And so I'm going to try to summarize it for you guys in case you don't read it. It's really a great way that they presented it. And so basically what happened was initially when they started, there was some study in China where they looked at, it was an observational study, where they, the people in United States, France, China, and South Korea, they said, hey, this looks like it might work. It may be helpful. And it's more like an anecdote than anything. It's not, there wasn't really a way to prove or disprove. And so I don't know how many of you guys know this, but the way that we can tell if a treatment has worked is using something called a double-blind, randomized, placebo-controlled trial. And what that means is that do you want to send them the link? Can you do that? Is that we take people and we put them in randomly, separate them into two groups, and they don't know which group they're in, which one's getting placebo, which one's getting the treatment. The doctor doesn't know, or the study developers don't know. They don't know. Sorry, I get distracted by the comments. They don't know who's getting the placebo and who's getting the treatment. And then they compare to see if there's success, because there's so much power in placebo. So we really need to pull that stuff out and see what is there really in effect. And so when we had these anecdotal stories. So then they did this study in France, and there were basically 36 patients. And this is the study that we're using, that everybody's talking about. Like, this is the study that showed that it works, and that our government and a lot of leaders are claiming, oh yeah, this drug is great, we should use it. There were only 36 people. The trial wasn't randomized. And then they didn't really, based on that, they don't really know if, like, because the doctors who picked who got the treatment, it could have skewed who did better and who did worse, because we all have bias. Not that anybody was doing anything bad or intentional, but more like, sorry, hold on, this is not good. So basically they had this really small study size. They didn't randomize it. And then the benefit was only looking at to see if they had the virus hanging out in their nasopharynx. The end point of the study wasn't looking like, did these people live longer? Were they intubated less? Were they, did they not get symptoms from disease? And not to say that that those aren't important things, looking at the virus, and if it's there, that maybe that would decrease the transmission. But with this, they weren't even looking at something that really mattered. And so we're worried now, if people start using this all the time, there's these risks of arrhythmias and side effects from it that can cause more harm than good. Some people have been having seizures from it. There's been cardiac effects. So it's very frustrating to me to start hearing people say that all the healthcare professionals should start taking it for prevention. That's just such a quick drive into something that could do harm that we don't know about. It's possible, but it just seems like such a quick jump. So I'm talking a lot. I'm going to stop. Do you guys...
Yeah, no, we agree 100%.
I think that was a good summary. Yeah.
The upshot, once again, is that it's so early to say. We're all wanting an answer, and we want to feel like there's something out there that we can take to either prevent it or not get sick, super sick if we get it. And really, kind of the answer is, at this time, we don't have that answer. And, we don't want to pretend like, we shouldn't all just be involuntary guinea pigs to see if this is really the case. And that's why we do have to rely on patients. We have to rely on rigorous methods to really get us the data to really say yes or no. And we're not saying that it doesn't work. We're saying we just don't know. And at this time, once again, going to the beginning, feeling comfortable, understanding we don't know, and for us to say we don't know, and we're constantly trying to find the answer, is the best we can do right now. So, lots of great questions people have asked myself and them as well about, can we get it? Is it safe? Should I be taking it? And really, at this point, the short answer is no at this time. Will that change in the future? Possibly. And that's why we're going to always keep you up to date. But we're not going to be too early on this. There's too much risk involved with unknown benefit. So going to that point from the beginning.
So do you have anything else you want to add? I was going to go on to the next thing.
No, I think that's fine. I think you guys.
Okay.
Yeah, there's other
Not at all.
questions. So quickly about the mask. Somebody asked about the mask real quick since we were on there. No need to wear a mask in your car.
No.
I
Unless
think
you're in the car with someone who's
you're right.
sick.
That's a good question. If there's a lot of people in the car, then yes. But if you're by yourself in the car, then not necessarily. And then some questions about treatments, other things about treatments.
Yeah,
like
so
plasmapheresis.
yeah,
all
a
this
couple
kind of
things
stuff.
that I wanted that people had asked about that I was
Ivermectin.
yeah. So actually was this question about this idea of cytokine storms. So and this is the other thing that's interesting to me about the hydroxychloroquine and the azithromycin and all of that. Like you think about what's happening with this virus, it gets in. And from what I understand, you guys can tell me, a lot of what we're postulating as hurting people is actually our immune systems turning on and then just getting carried away. It just goes out of control, and that's what ends up killing people. So that's what a cytokine storm is. It's like you turn on this system that's meant to recruit your body to help you feel better, and it just like sends so many messages that it doesn't work out so well for you. One of the parallels I read, and I wish I could credit this person who wrote this, but it's like if you turn on the fire alarm every 30 seconds and the firemen just keep coming into your home and spraying your home with a hose until now your home is completely destroyed. And that's what cytokine storm is. So one of the things that has a plausible mechanism that they're studying are these things called IL-6 inhibitors. They're these monoclonal antibody treatments. They're like these little targets that go in and attack the over-responsive cells and make them turn off. And so they're doing that in people who are really sick. Now, let's take it back. Let's just say that you get COVID, and the majority of people who get it, they actually don't have this happen, right? Like they just get better and their immune system is doing the right thing. Like it rang the fireman once for the fire. He came and put out the fire and everything was great. So now if you have COVID and now you like ring the fireman once and you're like, no, let me just turn that whole alarm off. And I'm going to take this IL-6 inhibitor and prevent myself from reacting. Well, that's actually a mistake, right? So hopefully you guys are following this. Like we don't want to give these aggressive treatments to people who have mild disease. So it's like, it doesn't fit for everybody to be on an IL-6 inhibitor or hydroxychloroquine or these more aggressive treatments when their body's having a natural immune response that's working for them.
Right.
So that was one thing I wanted to bring up because people were asking that. And then someone asked about ivermectin. Again, so early science. It's like, and I just talked about this, right? So you have this virus in a petri dish and you put ivermectin, which is an antiparasitic on, and it kills the virus. And it's like, well, great. What does that mean for people? Like, I just talked about how the problem is how your immune system's responding. Like it's not just, clearly it's the presence of the virus too, but it's a combination of those things. So like, does it make sense for us to make then a conclusion like, okay, we should all take ivermectin? No. So I want everybody to keep coming back to what we can control, which is the masks, the social distancing, the watching what's happening, the slow release into the community, the vaccine that's coming. All of these things are more important. Okay, I'm going to stop talking.
Mm-hmm.
Yeah.
And again, just with the point that's already been said, but just to reiterate that this is a moving target and we may have different recommendations next week when we come back and,
Exactly.
These things may change. But right now we just don't think the evidence matches up, is there yet to make a blanket recommendation for the very good points that Emilie just elucidated. So,
yeah. Okay, so people are asking, and this kind of goes with the timeline, is COVID-19 like cold or flu and that you can get it multiple times a year? We don't know that. It's possible. It's also possible that in the future, infections with COVID-19 will not be this severe. And then someone's asked, look at Fred's getting all into are not factors. Maybe we'll talk about that later. Okay, pregnancy. Sorry, Fred, we'll get to it.
Yeah, somebody asked about pregnancy. Is it safe to get pregnant? Try to get pregnant? What's the answer?
You want me to do this one? I feel like I'm talking a lot today, but I can. I did all this.
Yeah.
So let's see. So basically from what I was reading, there's not a lot of information about pregnancy with COVID. They looked at like one review of 38 women, and there were no cases of transmission of the virus to the baby during the pregnancy. And there were no maternal deaths. So then after that happened, then they said there were maybe several possible cases of in utero infection reported. So it's not like this it doesn't seem to be a big risk, but it's not no risk. Like, again,
the risk is the same as the summary is basically pregnant women and non-pregnant women. There isn't a worse outcome in terms of the mom. But there is a little bit of increased risk of like preterm labor, potentially. And once again, these are small sample studies, but it isn't this dire statistic where pregnant women are at more risk for a lot of things.
The other thing they're saying is like the whole preterm labor thing was like, because the women would, if you're pregnant and then you get pneumonia and they have to like intubate you, which again, didn't happen any more likely in pregnant women than other people who are low risk. They would induce labor because they thought it would just be safer. So that's why the preterm labor thing went up. It wasn't because it just happened naturally. It's because they intervened to help these women with their pneumonia. So someone asked, is it okay to try to get pregnant right now? I mean, I don't know how to answer that. It's like, where are we going to be in 9 months? Like, I don't know. You have to plan out your life. I feel like if I really wanted to get pregnant right now, I wouldn't hold off. But maybe
To me, it seems very likely that even if we do experience another wave this fall, even if we're not entirely out of the woods yet, it definitely seems like we'll have a much better handle on things. Even if things do resurface this fall, we'll be able to mobilize testing more quickly. We can maybe do some other methods that we weren't able to do this time, like more robust contact tracing and things like that. There were so many tools that we just weren't able to mobilize this time largely because the testing just wasn't available widely and early enough. And that is, there's a number of things like that will make it look different, even if we do have another wave later, and hopefully be more easier to control. So I think, to me, and again, Emilie, I don't know if you were going to talk about this a little more. To me, right now, it seems like bigger concerns for women that are pregnant are just the restrictions in hospitals right now. And, if you're close to time to deliver, it's very difficult to have anyone in a hospital with you for the delivery. How are you doing your visits with your OB right now? Your prenatal visits, all of those things seem like, things that are complicated and that we're working through. And it seems like all of those considerations, I am pretty hopeful that those won't be there as much in terms of the restrictions on visitors to the hospital and things like that in 9 months. But I think, again, back to the uncertainty, it's hard to say for sure. But those are some of the things to be thinking about, I guess.
Yep, totally. Absolutely. Okay, someone asked about vaccines and pregnancy. Again, if there's a vaccine, they'd have to be sure that it's safe during pregnancy. And we don't even know if it's safe at all yet because they're still studying it. So too early, but great question.
Yeah.
Okay, I'm laughing at your comments, guys. Okay, so next question is...
That's the only problem with doing
you
this.
can't see it, huh?
I can't read it.
Apparently, people named their
less fun
twins
for me.
COVID and Corona.
They're all making fun of you.
And
Shay.
they said they'd name their baby Quarantino, which that's a good one.
Quarantina.
That's a good one, Sarah. Okay, so can humans transmit COVID to animals? And what about pets? And what about the tiger in the Bronx Zoo?
I gave a wrong answer, by the way, last time.
Yeah,
I think I
see?
spoke with somebody.
A
and I
good example
that's a good learning.
of uncertainty.
Somebody asked me about dogs last week, and I think it was on a phone visit, or I don't think it was here, but I said no. I didn't think that it was something that you can give your dog. It's
That's what
possible.
we all had thought until this week.
Yeah.
But see, the thing is, like the thing that they say again and again, and I took this from a website. Oh my gosh, now I don't know what website I got it from. The OIE. Anyway, it seems like, although it's like theoretically, it's kind of the same thing. It's theoretically possible that your dog could go and have COVID and get it from you, but it is clearly not a huge part of this pandemic. It is clearly not contributing in a meaningful way to transmission of the virus. So I am not going to stop snuggling my dog because that would make me sad. And so I guess if you have what they say on this website is if you have COVID and you're isolating from your family, I guess you could isolate from your dog too, which is sad.
Yeah.
But maybe.
Once it goes back to, we don't have enough evidence to say that's really true or not. So we
it's
just
a tough
don't
one.
know.
And-
We don't know.
Right. And would it be worth the harms of that, to
Right.
you and to your your pet? And
Yeah.
Well, we haven't been hearing a lot of pet stories on
No,
COVID. So
I just think,
once again, we don't know.
we don't know.
Yeah.
Yeah, and I agree. Dogs help mental health.
Yeah.
And we all need mental health right now.
that website that Emily was referencing, if you want to read more on it,
thank
OIE
you.
is the World Organization for Animal Health. So kind of there's some
It's a good website.
international consensus statements there with the very limited data we have.
Yeah. Okay, so we need lots of time for this topic because we are excited to talk about antibody testing, what that means, what we're doing in our office, and all of this good stuff. So go ahead, James.
Yeah, so we're going to be doing antibody testing.
We're done.
That's it.
Come on over.
And so I started this with the whole discussion about uncertainty. And I want to start by saying the antibody testing is not going to give us necessarily the clearest answers that we want from the very beginning. That is, once again, this is a moving target. And the way we've discussed this in communicating with all of you as a group, as well as individually, is that, we're here to figure this out together. And so if we waited too long to get the right answer right away, it just takes too long. So we're approaching this clearly with caution and figuring out what the tests mean and what they don't mean, and what information we can gather from them, and how does that impact how you change your life, right? Because ultimately that's what we really want to know is, do I have it? Am I immune? Can I go out? And we talked about this morning, is we're already looking a couple months ahead, where when this starts to taper off, how are we going to do it? How are we going to reopen things? How are we going to open businesses? Who can go out in businesses? Are we going to do an age tier? Are we going to do a community zip code tier? Like, how is this going to work? And from what we've learned from other countries, there's a couple elements that are crucial to figuring out how to do it. The most important is testing, which we were late in the game to start. So now we have an opportunity to get ahead of that a little bit. And then the second component, which is going to be really important, is basically contact tracing. So when we start opening things up a bit, as you can imagine, we would all expect some cases to go up again. And that shouldn't be a surprise, knowing how it's happened before. And it shouldn't necessarily cause us that much anxiety if we have the right tools in place to control it. So once again, we talked about this earlier. We're a small practice. We're very fortunate to have all of you in our practice, but this is such a group effort, right? So we need the help of government agencies, businesses, everybody to be involved in figuring out how we can test people, how we can find out who's sick and who's not, and how to figure out how to isolate, quarantine in ways that are humane and also can help businesses start opening up again, help us lives again. And this is the unknown. So we're going to have to chart this together. It's going to be kind of this adventurous time, if you will, if you want to put a positive spin on it. So going back to the testing, I want to put it out there. So we're going to start testing. We've been doing the PCR testing. And to review that, what that does is it looks for genetic material of coronavirus. So when we've been poking in the back of your noses, that's what we're looking for. Do you have evidence of genetic genes, DNA, RNA of coronavirus in the back of your nose?
Or COVID-19 particularly.
COVID-19. If it's yes, we can't say if it's active, infectious, is it dead? We just know it's back there. So we have to put that in the context of your symptoms, where you've been, who you've been in contact with. And so that's, once again, an individual conversation you need to have with us, or if you're not in our practice and are watching this outside of that, with your primary doctor. It's such an important thing. All of these tests that we're ordering, not only here, but elsewhere, they are not standalone tools that give clear answers right away at this point in time. So that's the PCR test. The next test that we're going to be doing is going to be the antibody test, which we talked about last week. And what we'll kind of summarize today is what that does is what antibodies are. And this may be simplistic for a lot of you, but just to go back a little bit, when we see a bacteria or a virus or something that doesn't belong in our body, our immune system will create these little guys. They look like Ys that go around in our blood, and they kill things. And so that's our immunity, right? They poke them in the eyes, the Three Stooges style, and viruses do that too. They're very smart, but that's how we develop immunity. So we're testing to see if people have antibodies. The caveat is that doesn't necessarily mean you're immune yet. So it's very possible that you are. Once again, going back to all of this discussion, we're hammering home, it's very possible and likely, but we can't say for sure just because you have IgG antibodies, you are immune. We can start having that conversation. This is the first test, first step. And then we can also see there's two different types of antibodies. One where it can start in the early phase of disease. So some say 3 to 5, some say 5 to 7 days after symptoms start. You can form these, what we call IgM antibodies. And once again, MAD,
yes,
right? So the acute MAD phase.
Brilliant mnemonic.
So to that point, if you get tested, like I just got a fever today, I'm going to get an antibody test. You might not have the antibodies. It might be too early to see that. The IgG test, which is the GLAD phase of the immune system, can take up to a month, sometimes less, sometimes 2 weeks, sometimes 7 to 10 days. We're not sure specifically how this happens and for what people. But when we start seeing IgG, that shows that at some point in the past, it's suggestive that you've seen or been exposed to the coronavirus, aka COVID. All of the tests that are currently out there have some cross-reactivity with other coronavirus,
right?
Meaning not necessarily COVID-19. So putting that all together, we talked about this at length this morning. We have to put the whole picture together, meaning somebody says, I just came from New York a week ago. I had this flu-like symptoms. I feel better now. We do these tests. It shows you don't have the PCR, but you have the antibodies. We put our hats on and we come together and say, it sounds like it's most likely you were exposed to COVID and that you have antibodies that show you are susceptible to COVID or were exposed to COVID. Exposed to COVID.
And now you have an immune response.
You have an immune response.
But it doesn't mean that you're totally safe and you should run back to New York and lick the streets.
As you can imagine, we're just starting this test. The CDC just started testing this past week what these antibodies tests mean. So that means, just like Emilie said, if we go and I get COVID again, does that mean I have a robust immune system and I'm fine? We have no idea. We can guess, yes, but it's totally a guess. So people need to understand and appreciate that right now. And as we move forward, we'll have more information to confirm or change what we feel about the tests. So going back to the tests, I've been in talks. So hopefully this Friday, but most likely logistics next week to start doing 2 types of antibody tests. The one that we will discuss with everybody about is what we call it's sent out to a lab is the way we'll do it. Just like the PCR nasal swab test, it'll be at this point in time, the way we'll do it is our drive-up testing where we will come up to you, we'll be dressed in our funny gear, and we'll do the swab and we'll do a blood draw in a small tube, and send that out to the lab. The lab is located in San Diego called Genolite. And once they receive it, it's a fairly quick turnaround time, similar to what you've experienced with our PCR tests, to show whether or not you have IgM or IgG antibodies. That's the major test we're going to kind of push out there. Both the PCR test as well as this antibody test are covered, meaning you will not pay, if you're a member in our practice, for these tests. The Families First Coronavirus Response Act has stated that all private insurers, government insurers, including Medicare and Medicaid, will pay for all diagnostic testing completed at laboratories. So that means that these labs that we're sending them to, and I confirmed with Health Track RX as well as Genolite, that they should not be billing you for for these tests, regardless of insurance or lack of insurance. So that's number one. And so that workflow should be out next week. We're in the process of going through that and making sure that's fine-tuned. But next week, we should be able to start doing that. There's another antibody test that we are going to discuss with you individually and see if you're interested in. And it's what we call a point of care test, which means we do it in our office, and it's a 15-minute test. This is a super quick test in that it's a drop of blood. It goes on a little cartridge, and it'll quickly see if there's IgG or IgM. Since it's not being sent out to a lab, we have ordered these for us as more of kind of like an in-house testing type of quick 15-minute antibody test. And so it's kind of a preliminary result. And we would always send that we would do that always with the GenoLite test. So we wouldn't recommend doing that alone and making a lot of clinical judgment based on that one test alone. Since it's not a send out, it's a $15 test. And once again, it's an opt-in test. So it's not something that you have to take if you say you want an antibody testing. We're not going to just do all of these tests all at once. Once again, it's a decision making that should be made with us individually and figuring out your risk factors, what makes sense for your particular situation. And then the last piece is interpreting all of this. This is, to me, the most important part of this. And we talked about this as well. Different from just going and getting a test done. The biggest piece of this is how do you make use of this information? So that's where you really should rely on us to have these discussions with you. If it shows that you're positive, what does that mean? What should you do? Does that mean you can feel more relaxed? Should you stop social distancing? The quick answer is no. Do everything the way we're doing right now. But as we move forward in the coming months, it will start to determine how we loosen things up with it.
So I want to make 3 comments. One is that we have a historically used IgG. Thanks, James. That was good. We've historically used IgG or antibody testing to show immunity in the past. So this is not like a brand new concept. Like if you've had a measles vaccine or a hepatitis B vaccine, we'll draw your blood to see if you have, well, not with hepatitis, but with measles, to see if you have an IgG. And then we can say, yeah, you've been immunized or you're immune or safer, not totally safe, but safer to be protected against measles. So it's not that we have no idea if this works. It's just it hasn't been put out in the world yet. So like James is saying, the information I think is important to have. And then as time unfolds and we get more data on this, then you'll have that information and we'll have more understanding of how to use it. The second thing I wanted to say is those of you who did a nasal swab through the Texas lab we were working with and didn't have insurance and we told you it was going to cost $75, they have since told us they will not be billing anybody because they're following that law. So if you got told you were going to get charged $75, you are not going to get charged $75. If you get a bill from them, if you have questions about that, reach out to us. We're happy to help advocate for you guys. So just some clarity on that. And then the third thing was that the reason James and I and Shea, we went back and forth on should we get this point of care, this 15 minutes, it comes back test in our office, or should we not? We don't totally trust it. The reason we got it is we wanted to have resources available to you guys. We wanted to see what it started to look like, but to be totally transparent, I don't know if I totally trust it yet. So that's why James was saying we trust much more what we're hearing from GenoLite, this local lab, than we do from this point of care test. And so if we're going to do it, we're going to do it hand in hand with the GenoLite because we want to see that. But that's all. Yeah. Yeah.
This is early on. We're in a data gathering stage. So.
And someone just asked, why would you not do the point of care? Simply because we're going to charge you $15 for it. And it's going to test the same thing that we're doing the send out for. So it's like, you don't have to spend the $15. You can do it for free and send out. But if you just want that like 15-minute answer, or if you're just curious about the 15-minute test, we're happy to do it. We bought them. We have them in the office. We have them available. They're being shipped. We're going to have them available for you guys because we wanted that service for our patients. But we just want to be so clear that, like, I don't fully trust that right now as a standalone. Here, do this. and we're done. I hope that
It's
makes sense.
It's too early for these tests to have gone through the rigorous process to be approved by the FDA, right?
Right.
Both of them just
Right.
have this classification of emergency use authorization, or does the point of care even have that?
They're not authorized, actually. So that's
okay.
a good point. There's only one that was authorized under the emergency use authorization by the FDA. So I'll get a little geeky on you here. So there's no FDA approved tests for antibodies at this point.
Mm-hmm.
There's one authorized, and they sound like very similar words, but the FDA has not reviewed and done any studies on any of these tests because it's an emergency. What they're doing is they're looking and saying, hey, that looks pretty good. Go with it, right? Like, we got nothing right now, so please, let's try it out. Let's see what happens. But in all of the verbiage that I'm signing from a practice standpoint of view, and as we communicate to you, the FDA has not reviewed any of this, the data, I should say, behind any of these labs, or I should, at least the point of care, I should say, the one in-house. And that, once again, moving forward, we need to be just mindful of how we communicate the results and how we interpret that internally with you as well. So,
and that 15-minute test, the reason why we're a little questioning about it is the pamphlet that we got on it. It just didn't inspire a lot of confidence. A lot of people are using it.
I feel a little bit differently. But
okay, well, that's good.
Okay.
Yeah. They also aren't showing, like, I think you were saying that the threshold of which it becomes positive with an IgG is more clear with the San Diego lab. There's some technical things that we've been vetting out ourselves, and
Right.
You've been doing more of that than me. But just so you guys know, we've been really kind of pushing these things, reading backgrounds about this test versus that test, which is why we've come to this conclusion that we're a little more comfortable with the send out or the San Diego test that we're using. Yeah.
And specifically, so let me talk a little bit about tests specifically. I know we're cutting short on time, but antibodies react to a little particle on the virus. And so the send out that we're sending to the lab, they have 5 different proteins that it looks out for, antibodies to 5 different proteins versus just one on another. So it seems to be more specific to this particular coronavirus than just your quick 15-minute test where it might just be one little protein on the virus itself. So that's why I feel that, once again, kind of validating. And once again, I don't have super clear answers what's better or not, but we're feeling that it's more comfortable potentially making decisions based on the send out labs.
Now, should you get the test when you have no symptoms? Oh, go ahead.
Oh, I was just going to reiterate logistically. You said this, but to make sure everyone understands. So with all of this uncertainty, kind of a newness of these tests, we feel most comfortable with anyone that's going to get an antibody test. We're also going to do a nasal swab,
yes.
A PCR swab. And if you get this, the point of care test, like we're talking about, we're also going to send out the blood draw as well. So if we do an antibody test, we're going to do at least the blood draw and the nasal swab. And then if you decide to also do the point of care test to get an answer there in 15 minutes and you decide to pay the $15 for that, we'll do that as well. But we're also going to do the other 2. So there's not going to, and we might as well do that. They're covered. It's going to be free to you. We feel like, hopefully so early on in this, that's going to be helpful to collect more data, big picture, and, to help the medical community and the labs and all of us, understand how this works. But again, just to, as James and Emilie are saying, we'll just have to be very careful about then what we do with those results and how we use that to guide recommendations or behavior change. That's going to be tricky right now. But, the more we can begin to collect this data, hopefully the more clarity we'll get about all of that.
So when Fred just asked what's the accuracy, and we need to answer, should you do it if you're asymptomatic, in 1 minute. Accuracy from you, when you look at what the lab sends you, it looks amazing. It's like 98, 99% accurate on everything they do, but there's no outside reviews. So we have to be so careful about that, because it's like, they're trying to market their test, and they're reproducing these things in perfect conditions, and the world is not perfect. So, and that kind of gets to someone else's comment about how it's baffling that we don't have a test yet. It's not totally baffling, because science takes time. No matter how advanced and how much money we have in our society, it takes time to see how things are affected in the real world. It's not hard to make the test. It's hard to know how the test works in the real world.
Right. And the same with the vaccine. So the vaccine actually is not that hard to make. They've made like various prototypes. We just don't know which is going to be effective, right? So that's why it's going to take maybe a year to figure that out.
You have to do large, population-based studies, for this to be valid, for us to really know the safety of these things, and it just takes time.
So if you want to do the antibody test and you were never sick, I don't know. I don't know if you should do it. Maybe... I don't know. What do you guys think? You never had any symptoms?
Exposure. I mean, maybe if you're a healthcare worker, and you were taking care of a COVID positive patient, and you were in a very high risk setting, but you just never got sick. Maybe I think it could be useful, but that's going to be probably more rare. Right?
And I think they're asking about minor symptoms. I feel like if you're curious, I don't know. I kind of feel like, why not? But
I feel like
maybe I'm wrong.
Yeah. This might be one of those things like the testing. You guys have seen us go back and forth. There was 1 week there where we said, everybody come get tested. Then we said, I don't know, is this the best use of resources? And then we said, no, we need more data, come get tested.
Right.
To me, it seems like right now for this antibody test, it's so new. For most cases, we're going to say, yeah, go ahead and do it. But that may change next week. So.
Right. And we're going to have to interpret it. Like someone's saying they had symptoms, they had a negative COVID swab. So then if the antibodies are positive, is that a false positive? What does that mean? Like, do we repeat it later? Does it go, like, there's going to be so many questions. So I don't know if everybody should run out and get tested, especially over these next few weeks, right? We're coming to the peak.
Right.
We're super careful, but you're still kind of exposing yourself. Like Nancy and I are coming up to your car and we're sticking needles in you. Like, I don't know. Maybe you don't do it now.
And I do want to repeat the point I made.
Yeah,
the point is, like, does it change anything today?
Right.
Let's say we tested all of you today. What is it going to change tomorrow, next week? Really nothing. So if you're not having any symptoms, really at the end of the day, we're still social distancing. Businesses are not opening. People aren't going back to school. This is us taking an early step to figure out how to do this. What does this data potentially mean? So that in a few weeks, in a few months, we are already prepared to understand, like, okay, this is how we're going to approach and work with others to open up our schools, businesses, and whatnot. We don't have those answers yet. And that's why, once again, starting with the uncertainty and ending with the uncertainty, there's a lot of questions we have about it. We, once again, would love to speak with you individually because of specific circumstances. And some people may have been exposed, others might not have been. Maybe you're just really anxious and it'll help you peace of mind. That might be enough for you to really want to do it. That's where we're at right now.
And how long do the antibodies last? That's a really good question, because that would give us a sense of immunity. But to give you an answer on another disease, if you get a measles vaccine, your immunity can last for a lifetime. So if you have IgG, not always, but many times that immunity will last you for the rest of your life. So it depends on the disease, your immune response, all of that.
We just don't know.
But it's not like days and then it disappears and we miss the window to catch the IgG. It's nothing like that where you would rush out to get it. And if that were the case, then the point is to see, is there a possibility you could be protected from COVID? And right? And if we have more and more of those people, and so if your antibodies disappear that quick, well, then the answer is that you're not protected.
Right.
I think. Who knows? We don't know anything.
Figuring it out as we go.
Yeah.
So you're part of the process. So we invite you to once again ask questions, and that was part of it. Is hopefully once again kind of opening the curtain to how we're doing things, what we know, what we don't know, and how we can answer the questions with you as we move forward. So I think we'll end with that, unless there's something else you want to say.
No, I think that sounds good.
All right.
Thanks for
we
being
look
here
forward
with us.
to hearing from you.
Keep in touch with us.
Bye.